Good morning, everybody. I'm Dr. Heba Essam the professor of psychiatry in Alexandria University. Actually, today I am going to discuss with you a very important subject in psychiatry, which is schizophrenia. Schizophrenia is the most devastating psychiatric illness, and almost all psychiatric illnesses are present in such a disorder. Famous people have been affected sometimes by this disorder. Like you see, those cats are the product of Lewis Penn. Lewis Penn is a painter, a British painter, who has been famous for painting cats. And he spent some times of his life in the hospital because of schizophrenia. Our agenda today is we are going to discuss the definition of schizophrenia, the criteria of diagnosis, the etiology, the epidemiological facts, and the differential diagnosis. To start with, what is the origin of the word schizophrenia? Schism in Latin, it means splitting. Phrenia is mind. So schizophrenia is formed of two syllables, which is meaning splitting of the mind. So each part of the mind is not working in coherence with other parts. That's why the patient is seemingly bizarre in behavior and in affect. So it is splitting of the mind or disconnectivity syndrome. And this is not to be confused with dissociative identity disorder or multiple personality disorder, which often lay people confuse this name with schizophrenia. So, schizophrenia is one of the psychotic disorder. What is psychosis? Schizophrenia and other primary psychotic disorder are characterized by significant impairment in reality testing and alteration in behavior. And this means that patient became confused and he cannot actually differentiate between what is real and what is fantasized. Is these voices real or is the product of my mind? So there is impaired reality testing. Also, there is positive symptoms such as persistent delusions, hallucination, disorganized thinking, disorganized behavior, and experience of passivity and control. And later on, we are going to discuss those symptoms. Also, the third component of psychosis is negative symptoms, which is blunted affect or flat affect, as well as a volition and cognitive impairment. And finally, psychomotor disturbances such as catatonia. So there is four main symptoms to diagnose a patient with psychosis, which are impaired reality testing, positive symptoms, negative symptoms, and finally psychomotor disturbance. It's very important that those symptoms occur with sufficient frequency and intensity to deviate from expected cultural and subcultural form. And this is very important not to diagnose people without putting importance to their cultural background and their tradition. For example, in Egypt here, some people are putting blue hands in front of their houses, and they are convinced that this is important to push away evil eyes. If someone living in the United States, you tell him this, he will see this as delusions. And also the culture, the Indian culture, they used to burn the cadaver of people to help souls to go far and to be happy and to be raised. So this is in Indian culture and convictions. So some people will say this is delusions. So it's important in psychiatry. Psychiatry is one of the branches of medicine that is closely related to culture and traditions. Also, symptoms in psychosis do not arise as a feature of another medical and behavioral disorder. Medical disorders that might cause psychosis, like brain tumors, for example, or collagenic disorders or endocrinological disorders, and other behavioral disorders like mood disorders or substance-induced psychosis. The categories in this grouping should not be used to classify the expression of ideas, beliefs, or behavior that are culturally sanctioned, as I mentioned just before. And now you know what is psychosis. We will discuss the most important type of psychotic disorder, which is schizophrenia. What is schizophrenia? The diagnosis of schizophrenia in particular is based on the presence of disorders in thoughts, perception, experience of self, cognition, volition, affect, and behavior, which must persist for at least 1 month according to the ICD-11. Psychomotor disturbances such as catatonia may also be present, and the symptoms is not a manifestation of another health condition or substance of abuse or medical condition. This is the definition of schizophrenia. Schizophrenia actually, as I told you, is affecting almost all functions of the mind. So we can categorize the symptoms of schizophrenia into 3 main categories. First is the positive symptoms, then the negative symptoms, and the third one is the cognitive impairment. Positive symptoms, they are called positive because they are not present in the usual ordinary premorbid condition of the patient, and they are added on the patient with the affection of schizophrenia. So they are positive symptoms or added to the patient. Those are delusions, hallucination, mainly of auditory type, thought disorder like loosening of association and incoherent speech, and up to neologism. Negative symptoms, they are called negative symptoms or deficit symptoms because the patient is actually losing by minus, they are losing some of their capabilities because of psychosis. So it is counted by minus, it is negative symptoms like flat or blunted affects and emotion, poverty of speech up to alogia, inability to experience pleasure as anhedonia, lack of desire to form relationship, asociality and social withdrawal and isolation, and lack of motivation, which is called avolition. And finally, cognitive impairment, particularly the working memory and other executive functions like planning, organizing, and prioritizing. Those are the 3 main symptoms domain of schizophrenia, and we are going to discuss some of them just now. First is delusion. What is meant by delusion? Delusion is a fixed false belief, uncheckable by superior evidence of the contrary, and out of keeping with a person's cultural norms. So delusion is not coherent with the patient's cultural and educational background. For example, a scientist or a chemist who is telling you that my wife is putting poisons into my food. And actually, you can see that his wife is very keen to help him and to bring him to doctors, and she is very nice. And if you are going to discuss this with him and telling him, I'm going to eat with you from the same plate to prove to you that your wife is not putting any poisons into this plate, he will just answer to you and reply that this poison is going to react only with my body. So it is a fixed belief. It cannot be changed just by discussing the issue with the patient. He is believing on this idea. Examples of delusions like reference, persecution, control, bizarre delusions, grandiosity, hypochondriacal or somatic delusion, nihilistic delusion, and delusion of guilt. What is meant by delusion of reference? Delusion of reference means that the patient is convinced that everything and every act surrounding him is giving him a meaning. He is the reference of any act. So even if a presenter in the TV is talking about social problem, the patient is considering as this presenter is conveying to me a message, and he means to alarm me about my brothers and sisters who are going to take my heritage. This is an alarm. So if a red car is passing by the street, this means that they are actually putting cameras into my room, and this is to give a sign to them to start recording. So every act, every single movement around me, or every single talk that is occurring, they mean it that I am the one who is meant by this act. Delusion of persecution means that the patient is convinced that other people are doing harm to him, and they want to make him suffering. So, for example, they are now putting a plan to shut me away from my work. Or, for example, if he is going to enter an exam, an oral exam, actually the examiner has asked me a very difficult questions, not like other people. So, like there is a conspiracy about that people are going to harm me. And they are doing this by intention. Delusion of control, actually the patient is convinced that he is like a puppet, and people are going to control him. And sometimes we call this passivity phenomenon. So he is telling you they are withdrawing ideas and thoughts from my mind, or they are putting ideas into my mind, and this is thought insertion, withdrawing ideas from my mind, thought withdrawal, or everyone surrounding me can know my thoughts and my ideas, and this is thought broadcasting. So if you ask him, what are you planning for your day, he will going to tell you, but you know, everyone can read my mind and know what is my thoughts. These disorders are called delusion of control, because the patient is convinced that people can control his thoughts and his minds. bizarre and impossible delusion if, for example, the patient is going to tell you that there are aliens that are coming from another planet and they are going to implant electrodes into my mind, and like this they will help me to invent an instrument that will change the world. Those are bizarre, very bizarre delusion. Delusion of grandiosity, and those actually are common during manic episode rather than schizophrenia, but can occur in schizophrenia. So the patient is convinced that he has exceptional capabilities and that he is potentially more important than other people in the world. So he is telling you, for example, that he is a prophet and that God is telling him to tell people a message, and that he is directly connected to God, for example. This is delusion of grandiosity. Hypochondriacal or somatic delusions. The patient in hypochondriacal delusion and somatic delusion is usually suffering from depression. Hypochondriacal delusions, for example, the patient is convinced that he has a chronic or severe medical problem like HIV or cancer, and he is convinced by this, and this idea is not checkable and is not corrected by simple investigations or even complex investigations. And by somatic delusion, the patient is convinced that, for example, there is bugs that are walking into his skin and he can feel them. Nihilistic delusion, and this is characteristic of psychotic depression, but also might occur in schizophrenia. In nihilistic delusion, the patient is convinced that he is dead or part of his body is not present, and even sometimes the world is not existing anymore and has ended. And by delusion of guilt, the patient is convinced that he is guilty, and this is out of any proof. For example, he tell you that I'm not a good person, I'm guilty because when I have been 7 years old, I didn't go to buy medicines to my brother who was sick, and this means that I am not a good person. Actually, at 7 years old, he was not the responsible person. What is meant by hallucination? Hallucination is a perception internally generated in the absence of an external stimulus. And this is important in the absence of external stimulus, because if there is external stimulus and there is only misperception, this is called illusion. While in hallucination, this misperception is due to internal generation of stimuli, and there is no external stimulus. Hallucination in psychosis, and especially in schizophrenia, can occur in any sensory modality. It can be auditory, visual, gustatory, olfactory, tactile, or kinesthetic delusions. But in schizophrenia, it is mostly auditory type. It's mostly auditory hallucination, usually commending the patient or keeping a running commentary, so commenting about the patients, and usually it can be multiple voices talking to each other and not only a single voice. but sometimes also it is a single voice. Now in psychiatry, we actually have diagnostic criteria to make a final diagnosis to a patient. So in psychiatry, we depend on those criteria to be objective while diagnosing the patient. In the United Kingdom, the most recent classification is that of the WHO, which is called ICD, now ICD-11, which is the International Classification of Disorder, ICD, and this is the 11th version. While in the United States and also in Alexandria University, we are adopting most commonly the classification called DSM, Diagnostic and Statistical Manual, and now it's the 5th version. So we are going to discuss those criteria rapidly. In the ICD-11, the required criteria to diagnose schizophrenia, as you can see, you have at least 2 of the following symptoms must be present by the individual report or through observation by the clinician or other informant. Most of the time, for a period of 1 month or more, at least one of the qualifying symptoms of the 2 symptoms must be from item A through D. So you have actually 7 items, and you need 2 to diagnose schizophrenia. One of those 2 must be from A to D, or from the first 4 category of symptoms or criteria. The first criteria is persistent delusion. Then second one is persistent hallucination. The third is disorganized thinking, like formal thought. We are telling this as formal thought disorder. And you know that you can never judge the thinking of or the thoughts of a person except from his talk or his speech. So actually we know the pattern or the form of thoughts. We diagnose formal thought disorder from the way the patient is talking. For example, tangentiality, that the patient is just approaching the idea or the goal of the conversation, but it's not reaching the goal, or there is loosening of association. So there is some association that is connecting the patient phrases, but it is loose, not connected very well. Sometimes this became incoherent speech, that the phrases of the patient are not connected with each other, and if it is more severe, it became word salad. So the patient is not capable of forming phrases. He is just telling us words that are scattered and not collected into a formal phrase. And in very severe cases, the patient words become incomprehensible, and like the patient is inventing a new language, which is called neologism, new language. So the patient is telling as if he is talking Indian language, and he is or a language that you cannot understand. For example, he's going to tell you Hashafraosh, Anosh, Kalalosh, whatsoever. So it is a neologism or a new language invented by the patient, and he is keep running phrases that you cannot understand, and the patient language is incomprehensible. The fourth criteria is experiences of influence, passivity, of control, as I have just explained. the experience that one's feeling, impulses, actions, or thoughts are not generated by oneself, are being placed in one's mind or withdrawn from one's mind by others, or that one's thoughts are being broadcast to others. So, delusion of control or passivity phenomena are thought withdrawal, thought insertion, and thought broadcasting. The fifth criteria is negative symptoms such as affective flattening, alogia or paucity of speech, avolition, asociality, and anhedonia. And as you can remark, all of them are starting by the letter A. Grossly, the sixth one is grossly disorganized behavior that impedes goal-directed activity. Those behaviors appear often bizarre or purposeless, unpredictable or inappropriate emotional response that interfere with ability to organize behavior. So, for example, the patient is going to put all his clothes, for example, 15 clothes, and putting them all together at the same time and walking into the street and collecting, for example, the bottles from the street. So it's very bizarre, putting all clothes that he has and collecting bottles from the street. Very bizarre. Okay. Sometimes the behavior is not coherent with the situation or the thoughts, and this is because of the patient's poor judgment. For example, if the patient's father is dead and now there is a ceremony for putting the cadaver away and people are crying, then you see that the patient is very angry and he is shouting, and when you ask him what is going on, he will tell you, I'm not finding the remote of the TV. So it's very bizarre and it's not in concordance and it's not adequate for the situation. The final criteria is psychomotor disturbances such as catatonia or catatonic restlessness or agitation, posturing, waxy flexibility, negativism, mutism, and stupor. I know that you have already discussed what is meant by catatonia, but all those catatonic criteria or features are considered psychomotor disturbance. For example, in waxy flexibility, the patient can be shaped or moved as if formed of a wax. So if you put the patient's hands like this, he will keep this position as if a statue made of wax, and he will keep this position surprisingly without any sense of fatigue, and he might keeping this for days and hours. Finally, the symptoms are not a manifestation of another medical condition like brain tumor and are not due to the effect of substance of medications, substance like corticosteroids, for example, or medications like corticosteroids, and substances like amphetamines or stimulants that can induce psychosis. And it's not due to withdrawal effects of substance like alcohol. And this final criteria is very important in the differential diagnosis. Now, the DSM-5 criteria is almost the same as the ICD-11. We have to diagnose two criteria that at least 1 month should be of active psychosis, and those criteria are hallucination, delusion, disorganized speech, grossly disorganized or catatonic behavior, and finally negative symptoms like affective flattening, alogia, or evolution. But in DSM-5, the main difference that they should be continued, those symptoms, 6 months, but we can count those 6 months starting from the prodroma or the attenuated symptoms and also the residual symptoms, and not only the 1 month of active psychosis. While in ICD-11, the 1 month of active psychosis is sufficient to diagnose schizophrenia. Now, let's practice. This is a case. We will read it together and we will ask a question. A 26-year-old man who is a medical student with no prior psychiatric history is referred to your office by the dean of students. The student's friends came to the dean with concern that he has not been going to classes for over a month. They reported that over the past 6 months, he hasn't seemed himself. He's been more withdrawn and he doesn't seem to be doing as well in his classes. After he stopped going to class, they went to his apartment to check on him. They became scared because his apartment was filthy. He had taped aluminum foil over all the windows, and he kept telling them they had to leave before they became targets too. The patient appears disheveled as though he hasn't showered or brushed his hair in over a week. He clutches the notebook to his chest with all the proof of the conspiracy written inside. When you ask to see the notebook, he quickly opens it to a random page which you see is covered with words scribbled in no organized fashion. He reports feeling depressed because they will eventually catch me and torture me for the secrets. Who wouldn't be depressed? He denies changes in sleep or appetite, but admits he has run out of food at his apartment and has been too scared to leave to buy more groceries. He would love to play basketball, his favorite hobby, but states, "I don't have time because I have to protect the secrets." On mental status exam, he is unkempt, he has poor eye contact, and his eyes constantly dart around the room. His affect is blunted. He is suspicious, asking several times, "Are you in on it? How do I know you are not in on it?" He denies hearing voices, but you notice him frequently turning to the side and mumbling under his breath. He denies using drugs or alcohol because "I have got to stay sharp." He denies suicidal or homicidal thoughts. Now, we will going to practice. They will eventually catch me and torture me for the secret. This phrase mostly imply delusion of persecution, delusion of grandiosity, negative symptoms, tactile hallucination. They will eventually catch me and torture me for the secrets. Take few seconds, more few seconds. Yes, it is delusion of persecutions. Now, you are going to spend sometimes, you are going to stop the video and fixate on the case, and to practice more, you will going to categorize the symptoms that have been mentioned in this case into the three main categories of schizophrenia, the three main domains of symptoms of schizophrenia: positive one, negative one, and cognitive symptoms. And like this, you are going to memorize very well the symptoms of schizophrenia by practice. Now, what is the etiology of schizophrenia? Schizophrenia actually is a neurodevelopmental disorder. So it is the product of an interaction between genes and environment. So there is a genetic susceptibility, and this is precipitated or started by environmental stressors. And this proved by family studies and also by twins study. You know that the general prevalence of schizophrenia all over the world, the mean is 1%. While if you have one first-degree relative affected by schizophrenia, your chances to develop schizophrenia is about 6 to 7%, so 6 times more than the general population. If you have your parents, one of your parents affected by schizophrenia, the chances are raised by 15 times more than the general population. It is very common to have schizophrenia if you have one of the family member affected. So those are family studies. But actually, twins studies find that monozygotic twins, which have the same copy of genes, actually proved that the environment play a very important role, because in twins study, they found that the concordance rate between monozygotic twins is only 50%. 50% means that the environment play half the role for developing schizophrenia, because if it is only controlled by genes, it would be 100% concordance rate, because monozygotic twins carry the same copy of genes. This is to illustrate the interaction between nature and nurture, which are important both for the development of schizophrenia. For example, in nature, you may inherit stress vulnerability, cognitive vulnerability, problem in neurotransmitter systems or neuroplasticity. Those are polygenic risk score. But also cumulative environmental stress like obstetric events, abusive childhood, exposure to virus or toxins. Marijuana or cannabis is a very common precipitating factor in Egyptian culture of psychosis. Traumatic experiences or being exposed to bullying, or those stressors interacting with polygenic risk score are going to precipitate schizophrenia and the manifestation of hallucination, delusion, and so disorder start. Some epidemiological facts. The first that is the prevalence worldwide is about 1% of the population. It is slightly more common in females. The peak age of onset is late adolescence and early adulthood. Psychosis is more severe in males. Excitement at presentation mostly occur in younger age with no gender difference. Disorganized behavior at presentation is more common in young age and more severe in males actually. Negative symptom severity at presentation are more severe in males. So now we are going to just see some graphs that illustrating those epidemiological facts. This is a graph that is showing the age of onset of schizophrenia and the frequency. So on the axis, the horizontal axis, is the age, and the vertical one is the frequency. You can see that the peak age of onset is late adolescence and early adulthood, 20s, and that females are more common than males, especially at earlier age. Here, the psychosis severity, the horizontal axis is the age at onset, and the psychosis, mainly hallucination and delusion symptoms. As you can see, women are presented as a rose circle, and men as a blue triangle, like cognitive stereotypy. So you can see that the severity of psychosis is mainly during the 20s to 40s years, and the horizontal lines, the first one marked by 3 is mild symptoms, 4 is moderate symptoms, 5 is severe symptoms, and above very severe symptoms. So very severe symptoms of psychosis are more common in males, as you see, and severe symptoms are common at earlier age. These graphs is for negative symptoms. The same. Negative symptoms are more common at younger age, like all schizophrenic symptoms, and also moderate and severe symptoms are more common in males. Those are excitement symptoms. As you can see, there is no difference between males and females all through the ages, and the severity is the same, but totally excitement symptoms are common into young age excitement. The patient became aggressive, agitated, can hit people, or making, for example, accident with them. This is excitement symptoms, and this is common at young age, and it's not a symptoms common in older ages. Disorganized severity at presentation, as you can see, it is also commonly distributed between males and female, and also it is a presentation at young age and became improved with older age of onset. Also, substance misuse is very common in schizophrenic people, even before starting symptoms of psychosis. Schizophrenic substance misuser, for example, have a greater chance of persistent low-grade psychotic symptoms. They have a greater chance for later on developing schizophrenia with earlier start and heavier use increase risk more and more. They become 2 to 5 years sick earlier and younger than other people. They have worse outcome in every respect. So substance misuse is a predisposing factor to develop schizophrenia. Also, nicotine smoking, as you can see from the graphs, that in the general population, about 30% of people are consuming nicotine or cigarette smoking, while in schizophrenic first episode schizophrenia, the first episode schizophrenia, not because of medication or any side effects, about double the time the general population. So about 60% or 65% actually of schizophrenic are consuming nicotine. So maybe this because of a genetic predisposition in them, and this is also approved, but the fact that by the fact that sibling, about 45% of them, so more also than the general population, the sibling of schizophrenic are consuming nicotine. So nicotine smoking is more common in schizophrenic people, and cardiovascular risk and almost all health risk are more common in schizophrenic people. Here, this graph is actually showing you a score that is making you knowing the risk of developing cardiovascular disease. The most dangerous part is the red one. If you have 4 risk factors, cholesterol is high, blood pressure high, diabetes mellitus high, or cigarette smoking. So schizophrenic people actually lie into the gray zone with at least 3 factors. Most of the schizophrenic people, they have either high cholesterol, high blood pressure, high prevalence of diabetes mellitus, and they are mostly smoker. So at least they are collecting 3 factors, so they have high risk of developing cardiovascular disorder. And not only cardiovascular disorders, generally people with schizophrenia has a poor general health status. And I want to tell you a story about this. While I was a resident, we have had a chronic schizophrenic patient that is telling us every time that he is the emperor of the other world, and that he has jewelry into his stomach, and this jewelry are very precious, and that's why they are exposing him to electromagnetic forces. The aliens are exposing him to electromagnetic forces and waves just to collect the jewelry that are present into his stomach. So we know this patient, and every time he came to the hospital in a relapse, he is telling us the same story. One of the times that he was hospitalized with an active episode of psychosis, we have been very busy as resident, so his sister came to us and telling us that he has stomach aches. So the resident who was responsible just telling her, okay, I will see him later on, I will see him later on, and he continued to work. Later on, she cried and to come to ask us, he has very severe colics, he has stomach aches, and the resident have been saying, yes, this is because of the jewelry into his stomach. I'm going to see him. And while he reached him, he just see his abdomen, who was very extended. For the first time, he see his abdomen very extended, and by observing him, he asked him and his sister, have been him defecating last day? So the sister is telling he has not been defecating or even passing any flatus for 3 days. So this was very alarming to the resident, and he put the patient into emergency ultrasound. He prescribed emergency ultrasound, and the surprise was that the patient has intestinal obstruction. And actually, we opened the operating room. The surgeon came, but the patient actually has been complicated by intestinal perforation, and actually he died on the operative theater. This sad story telling is just to convey a message to you that don't take the patient complaints lightly. Take it seriously. Consider each complaint that the patient is telling to you, even if the patient is schizophrenic and psychotic and having delusions. Okay? And finally, suicide risk in schizophrenic patient is high, almost 1% per year, and eventually 4 to 6% of some cohort and 8% of some case control studies are recording suicide in schizophrenic patients. And this 4 to 6% is actually not the true prevalence of suicide, because half of the serious self-harm or suicide attempt occur before the first episode of schizophrenia is treated. So maybe these 4 to 6% are those who have survived till reaching the service and taking their treatment, and half of those who have tried suicide already, they committed suicide and died before reaching services and receive treatment. Also, homicide risk is increased in those schizophrenic people who does not receive medications. So before receiving medication, it's about 19.5 homicidal attempt per year, while it's reduced to 12 homicidal attempt per year in those who are receiving medication. So it's very important to start early medications for psychosis to prevent homicide and suicide risk. And the differential diagnosis of schizophrenia, as in other usual psychiatric illness, you have to exclude other psychiatric illnesses like bipolar disorder, manic episode or depressive episode, exclude obsessive compulsive disorder, other psychiatric illness that might mimic schizophrenia, and exclude other medical and neurological conditions. For example, medical conditions like systemic lupus erythematosus or collagenic disorders, because they might present with psychotic-like symptoms, neurological conditions like brain tumor or multiple sclerosis, and finally substance of abuse or medications that are presenting or having adverse effect precipitating psychosis like corticosteroids, or substance of abuse like stimulant as amphetamines. Finally, I have finished with you the first part of schizophrenia lectures, and I'm going to continue other parts with you next time. Thank you a lot.